Good morning, good afternoon, wherever you're joining from. We're going to get started in just a minute. Hello, everyone. Thanks for joining today's webinar. We're going to wait just another minute for folks to log on. Okay, hi, everyone. Thanks for joining us for today's webinar. I'm Sarah Bentley, and I'm a research coordinator at the Michael and Susan Dell Center for Healthy Living, housed at the UTHealth Houston School of Public Health in Austin. Aside from serving as a project director for the STREET study, which is Safe Travel Environment Evaluation in Texas Schools, which focuses on transforming city landscapes into healthier environments with innovative urban planning, I'm also involved in nourishing the community through culinary medicine, a study to pilot test a virtual culinary medicine program with adults with uncontrolled type 2 diabetes. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living. The center's vision is healthy children in a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. Thank you to the Michael and Susan Dell Foundation for providing funds to the center, including today's webinar. Next slide, please. So information for the center's work and resources can be found online. Next slide. You can scan the QR code on your screen to access our health resources. I'll give you a second to scan that. There's a lot of great resources there. And on the next slide, you'll see that our center also leads the Texas Research to Policy Collaboration project, which creates the legislative-related resources described on this slide. You can scan the QR code here to learn more as well. All right. The slides and a recording of the webinar will be archived on our website, and if you have any questions during the presentation, please enter them into your questions chat box. There will be a Q&A at the end of the presentation. Today's webinar is also held in conjunction with Diabetes Awareness Month, which serves to amplify awareness about diabetes, its impact on individuals and communities, and the importance of prevention and management. Throughout this month, advocates, healthcare professionals, and communities unite to educate, support, and inspire action. Without further ado, I'd like to introduce our speaker today, Dr. Natalia Heredia. And Dr. Heredia is the assistant professor in the Department of Health Promotion and Behavioral Sciences at the UTHealth Houston School of Public Health and a faculty member of the Michael and Susan Dell Center for Healthy Living. Her research endeavors include seeking to identify the psychosocial and environmental factors that influence physical activity and dietary habits. Employing a mixed methods approach, Dr. Heredia aims to harness this understanding to develop, implement, and evaluate interventions aimed at enhancing lifestyle behaviors and preventing or managing chronic diseases. Her primary research focus lies in promoting physical activity and fostering healthy diets with Hispanic, Latina adults and families. Now, here is Dr. Heredia with her presentation on prevention and management of type 2 diabetes through the integration of cooking skills into nutrition education. I'll hand it over to you.
Thank you so much, Sarah, for that lovely introduction. And again, my name is Natalia Heredia, and I'm going to be presenting to you today on hopefully something that you all will find very interesting, culinary medicine. To get us all on the same page, I just want to orient you all to the diabetes prevalence in the United States over time. You all may be more familiar with the obesity maps that are produced by the CDC and may have seen those many times. These are the corresponding diabetes prevalence maps. The darker colors here in blue indicate higher prevalence. So you can see pretty clearly over time that the prevalence of diabetes has steadily increased across all parts of the United States. And because we're in Texas, I want to talk for a second about Texas more specifically. The prevalence of diabetes in the US, again, like I said, has been steadily increasing. And Texas specifically follows that same trend, with the prevalence in Texas consistently higher than that US prevalence over time. And there's an apparent recent widening of that gap that you can see towards the end of that graph. And there are also persistent disparities in racial and ethnic minority groups compared to non-Hispanic white populations. Here we see that although the diabetes disparity in the Black community is not as great in Texas as in the US more broadly, there is still a pretty stark difference with the prevalence of 13.8 in Black versus 10.6 in non-Hispanic white individuals in Texas. And the prevalence in the Hispanic community in Texas is similar to that of the US more generally. But again, you see here that the prevalence, there's a higher prevalence of diabetes in the Hispanic community than there is in the non-Hispanic white community. So to talk about how we got to where we are and where we need to go from here, we have to talk about diet. We know that diet plays a significant role in both the development of diabetes, and it is critical when you're talking about lifestyle behavior changes to help manage diabetes and control HbA1c levels. Across the US, there's very low adherence to the dietary guidelines for Americans, about 10%, depending on what publication or metric you're looking at. These diets are poor quality because they're high in ultra-processed foods, and they're low in fruits, vegetables, and whole grains. And that aspect, coupled with low food literacy and a lack of cooking skills, may all be culprits in the high levels of type 2 diabetes that we're seeing over time. While patients may be told they need to eat healthier, physicians rarely have the time, or sometimes they don't have the nutrition-related training they need, and patients often state they do not know how to eat healthier. They may not have healthy cooking skills, which is problematic given that one of the key ways to sustain healthy eating is to cook at home. We also know that people with better cooking skills and actually with healthier cooking practices have a healthier diet and may also have improved weight loss compared to those with limited cooking skills or those that maybe even have less healthy cooking skills or practices. And interestingly, people with better cooking skills may also be able to save on food costs over time. So another advantage to cooking at home. Given what we already know from the research, we really need to equip individuals, especially those that we know that are already at risk for or already have type 2 diabetes, with healthy cooking skills and the nutrition knowledge so that they can succeed in actually following those doctor recommendations to eat healthier. So why culinary medicine? And what is culinary medicine? So culinary medicine is an evidence-based approach that blends the art of cooking with the science of medicine to help build that healthy dietary pattern that people can sustain over time. It's really an experiential, truly hands-on culinary nutrition education, and it helps participants overcome barriers they may have to eating healthier. Culinary medicine can add to the current nutrition interventions that we already have by incorporating that practical hands-on preparation of food and also focusing on creating joy when eating healthy foods rather than just an experience we have to get through, right? But importantly, we don't lose the key educational pieces that our programs focus on: nutrition, how dietary patterns affect health, and especially how that might impact getting diabetes amongst a pre-diabetes population, or how diet is critical to diabetes management for patients that already have the condition. So that brings me to our programs that have incorporated culinary medicine, or if you prefer, as I titled in the talk, the integration of cooking skills into nutrition education. First, I'm going to talk to you about type 2 diabetes prevention. We have a program we developed and pilot tested called SCAN, or Sustainable Culturally Adapted Nutrition Program, which we integrated into the ongoing delivery of the National Diabetes Prevention Program in clinical and other community settings. This was done as part of funded work with the Texas Department of State Health Services, where we created bidirectional referrals between clinics and the community programs that were certified to deliver the National Diabetes Prevention Program. Before I go any further, I want to acknowledge our funders and the team. So our past and present SCAN team, that's internal to UTHealth, as well as the Hope Clinic staff, our partner clinic. Our work was funded through Texas DSHS, through funding from the CDC. And as a disclaimer, the contents of this talk are mine and are my co-authors and do not necessarily represent the official views nor any endorsement by Texas DSHS, CDC, or the US government. So we encountered several barriers when helping clinics implement the National Diabetes Prevention Program, which I'm just going to call DPP from here on out. For those who don't know, DPP is a CDC recognized evidence-based program to prevent type 2 diabetes through sustainable lifestyle changes and weight loss. However, program attendance and the completion of the program do remain low, and that results in reduced effectiveness of the program. So from varying experience with clinics who were trying to implement DPP, as well as a review of the literature, we found that program adherence can be partially influenced by two things, many things, but two things that we're going to focus on here. The first is the affordability of healthier foods. The perception that many have is that healthier foods are more expensive, and that can be true at first glance. And the other issue we see a lot is that when we are appealing to various groups who are at risk of diabetes, there's a sense that if they adapt to a healthier diet, they might be taking away some of the foods they've grown up with and that they identify with culturally. And as you might expect, if they have those perceptions, that can be a barrier to both attending the DPP classes and to making sustainable changes in their diet. So we had tried to address these issues with the SCAN program. So again, what we really were trying to address with SCAN was attendance to DPP. So if you look at the literature, again, the success of the program for preventing diabetes is proportional to the number of sessions they attend. So we really wanted to create a hook to get people enrolled and to stay and hear what the DPP sessions were all about. SCAN focused on decreasing participants' environmental barriers, in this case, access to food, and personal barriers such as difficulties in the preparation of healthier versions of culturally appropriate meals, maybe a lack of cooking skills and motivation, with the ultimate goal of improving attendance and adherence to the DPP. And just for those who are not familiar, the DPP program is a 22-session program delivered over a year. Each of the sessions focuses on some aspect of nutrition, physical activity, or behavioral change more broadly. The most intense period is the first 3 to 4 months with the initial core sessions, and then there are maintenance sessions delivered at the back half of the program. So SCAN was composed of 4 main strategies that we integrated along with DPP. The first were cooking lessons. So we were able to pull on the existing Nourish program and the Nourishing the Community Through Culinary Medicine program, which is actually a program I'll talk about later in this presentation. So we pulled from that program, and the cooking focused more on cooking skills and techniques rather than a strong emphasis on specific recipes, so that we could make it more applicable for people with different backgrounds. The second aspect was motivational interviewing. For those of you not familiar, it's a guiding style of communication that sits between good listening and directing people. So it's designed to empower people to change by drawing out their own meaning of importance and their own capacity for change. So the coaches who are delivering these classes receive training in motivational interviewing, and I'll talk more about that training in a minute. We also implemented a food prescription program. The clinic that we partnered with, which was a federally qualified health center, implemented healthy food prescriptions, and we partnered with the Houston Food Bank to give participants food as a way to help improve access to healthy foods, trying to deal with that affordability aspect that I mentioned earlier. In FoodRx, providers give a food prescription to their patients, And then the participants received a food RxID card, which they used to obtain the food twice a month for the duration of the DPP program at one of several different local distribution centers. And lastly, we had incentives. So these included cooking tools helpful for making the class recipes and the ingredients needed for the class recipes. The coach training involved hands-on culinary technique training. So again, we partnered with a federally qualified health center who was implementing DPP already, and they had actually recently hired a chef, so very unique. So we did have the advantage of having one individual or one implementer of the program with extensive culinary knowledge. The chef, though, was paired with a social worker at the clinic, as we needed both individuals during the delivery of the actual program. And both received training on cooking the specific recipes with a specific focus on what and how to communicate during the sessions, but a little bit less of a focus on vitamins and mineral content and more things related to like flavor and taste and promoting those aspects of eating healthy food. The coach training also involved one-on-one training with a motivational interviewing coach who not only talk about the history and theory of motivational interviewing, but also some of the principal tenets of motivational interviewing techniques. And again, more importantly, how to incorporate these techniques when delivering the courses to allow the space for participants to open up and talk about their own style of cooking, their own culture, what foods are meaningful to them throughout the course of the program. And then there were adaptations that were both surface level and deep level adaptations. So surface level cultural adaptations refer to things such as altering the language or the images and the materials so that they reflect the target population, whereas deep level adaptations truly get at the culture and the values, and it involves a more fundamental shift in how something is conceptualized or delivered. So in this case, actually, we use both surface and deep level adaptations. So for SCAN, those adaptations included obviously surface level Spanish, offering them in Spanish as well as English, the tailoring of education and promotional material such as recipes, pamphlets, and images to include content that would resonate with those participants' cultural backgrounds, and discussion questions that were part of each session to identify participants' cultural background, their preferred food choices, how to use food substitutes to create culturally relevant, healthy recipes that may be similar to things that they already enjoy, and some other similar adaptations. So here are the 4 main classes that we integrated into the delivery of the DPP program. The recipes were selected to teach a specific cooking skill, and we focused on a major identified gap of being able to cook vegetables in a healthy way. So that first session was knife skills. So participants learned and practiced safe and effective knife skills to cut a variety of vegetables into even sizes. And that first recipe was Texas caviar with dressing that highlighted collard greens. So some takeaways from that class were to utilize the entire vegetable to potentially reduce waste. In this case, chopping up the stem small on the collard greens instead of tossing the stem, and using those small pieces to create a crunch similar to celery. So the second class was roasting. Participants learned the step-by-step process of how to prepare and roast flavorful vegetables, how long to cook them, and general temperatures for cooking the vegetables. And the recipe was tahini spiced roasted carrots. And one of the main takeaways was you don't have to peel the vegetables. That not only saves you time and maybe makes the cooking process easier, but the skins also contain a lot of important nutrients. The third class was sauteing. So people learned how to safely prepare and saute yummy, flavorful vegetables. This included what oils to use and the advantages and disadvantages of the different oils, incorporating different vegetables that people typically use and where you might get them. And this recipe again featured tahini, and it was tahini and oregano sauteed winter vegetables. Here, maybe some takeaways were that you could customize to your preference, as I mentioned earlier. So talking about the various types of winter vegetables that can be used, like various squashes, parsnips, potatoes, depending on people's preferences. And then lastly, microwaving. So they learned how to cook flavorful vegetables in the microwave. So this time it was garlic and herb butter broccoli. And the main thing we wanted them to learn here was how to cut vegetables in a uniform size so that they can cook uniformly in the microwave. And again, the substitutes of other vegetables that they can also cook in the microwave if they didn't like broccoli, for example. As part of these classes, we normalized failure. And what I mean by that is that we asked people to tell us what they didn't like so that we could help them find workarounds or alternatives. For example, if they didn't like broccoli, what alternatives they could use. And as we taught these classes, people tended to open up about the various foods they eat, what foods they find important to them. And this allowed the instructors to talk about each of these main skills, the knife skills, roasting, sauteing, and microwaving, in the context of cooking vegetables that are culturally appropriate and align with the cuisine that they're used to. So we ran a small pilot study that was a quasi-experimental design where we selected 2 cohorts to receive the SCAN program from the upcoming cohorts at our DPP partner clinic, and then 2 who would serve as the control. So the intervention was, again, receiving the 22 sessions of DPP along with the 4 SCAN classes, and then the 2 DPP cohorts that served as control were just receiving the standard 22 sessions of DPP. The participants in the intervention group were younger. They were more likely to be female and Hispanic compared to the intervention group, and you can see all of their demographics listed here. So at 6 months into the national DPP program, attendance was higher among participants in the intervention group or those that were receiving SCAN compared to those in the control group, but you can see it wasn't a really big difference at all, and it wasn't statistically significant. So 6.87 compared to 4.14. But even though SCAN sessions were not statistically significantly different between the intervention control group, or sorry, attendance was not statistically significant between the intervention and control groups. Attending SCAN sessions did show an association with weight loss, which is one of the main outcomes of DPP. So the figure on the right, we see the number of DPP sessions along the bottom and the average weight loss along the y-axis. And the dotted line, yes, the dotted line is control and the dashes are intervention. And so we see for given the same number of classes for DPP, the intervention group actually lost more weight compared to the control group. And originally we had 15 people in the control group and 22 people in the intervention group. And the analysis I just showed you was based on that breakdown. But about 10 people in the intervention group did not attend a single SCAN session. And so we wanted to actually look at the characteristics and outcomes by actual attendance of SCAN. We know that they didn't attend for a variety of reasons. Some had time conflicts. Some never responded to our reminders since they had to kind of enroll in a separate program in addition to the DPP. And some just didn't show up for the culinary medicine classes after we talked to them about it. But the breakdown in who actually did and didn't attend can be seen here at the top right. 12 people attended 1 or more SCAN sessions, and their demographics are here in yellow, whereas the demographics for those who did not attend any sessions are in gray. So we found that those who attended 1 or more SCAN sessions attended on average 2.5-ish more DPP classes than those who did not attend any SCAN sessions. But that difference also still wasn't statistically significant. But compared to our other analyses, we can see that SCAN participation, even maybe 1 class, could potentially help with retention into DPP. And we see a similar figure for weight loss that we saw before here on the right. Here, those who did not attend any of the SCAN sessions, whether assigned to the intervention or control originally, are the kind of small dotted line, or what is labeled there as intervention 0. And those who attended at least one of the sessions, or the dashed line there, are labeled intervention 1. So again, over the same number of DPP sessions attended, those who attended at least one scan session had more pronounced weight loss than those who did not attend any sessions. And lastly, we did qualitative interviews with some of the participants at the end of the program. Most had a great experience with the program, and here are some of the quotes of those individuals. So cooking the food, and the food they give to us in the classes, so it really aids a lot. Another one said, I love the cooking habit. I realized I was eating a lot of junk food, the types of foods that were not healthy for my life. So this program opened my eyes and really made me understand what I have to do or how to cook food, what to eat in the morning. I like it. I love it. Yeah, opened my eyes to a lot of stuff. So those people really liked it. Again, we did have scheduling conflicts. So one individual said, sometimes my work schedule, but not too much. Sometimes it was a little complicated because I have children, so I could not be there at the time that the program started. So again, time issues for attendance to the classes. So in summary, our small pilot study found that we could integrate cooking classes into the delivery of DPP, so it was feasible, which was the main outcome. Scan may help with the retention in DPP classes, though we need more research on that. It may also help with one of DPP's main outcomes, which is weight loss. Again, this was a small pilot, and we will need a larger trial to truly test the effect of the program. So now I'm going to talk to you about a different program more focused on diabetes management. This program is called Nourishing the Community Through Culinary Medicine. And there are actually several iterations of this program, but this particular program that I'm going to talk to you about today was funded by Blue Cross Blue Shield of Texas, and it was delivered in partnership with Sanitas Medical Centers here in Houston and in Dallas. And before I get started, I just want to acknowledge our funder, Blue Cross Blue Shield of Texas, as well as the current and past team who are listed there. So the goal of the study was to pilot, test, and evaluate a 5-session bilingual, offered in English and in Spanish, culturally targeted virtual culinary medicine program to promote cooking and healthy eating amongst patients who were already diagnosed with type 2 diabetes and actually had elevated HbA1c. We partnered with Sanitas Medical Center, again in Houston and Dallas. We could, although we're based in Houston, we could do Dallas because it was virtually delivered program. So criteria was just that they had to be adults, they had to have type 2 diabetes, they actually had to have HbA1c over 7, and because Sanitas only accepted Blue Cross Blue Shield, they just had to be insured by Blue Cross Blue Shield. So a little bit about the actual intervention. We see our registered dietitian and instructor there, Diana, in our teaching kitchen at the UTHealth School of Public Health in Houston. You can see the setup to be able to see multiple views where you can see her head on, but also from above, so you can see the countertop and what she's doing. There's 5 sessions that are about 90 minutes long, and we had cohorts that were either English or Spanish, and they were virtual but synchronous. So they happened at a specific time, and they happened in the evenings, starting before dinner time, so that people could make the recipes and then actually eat with their families. So the recipes were made for a family of 4. And Diana would lead the class and she would follow a recipe, but there was also a lot of teaching of basic cooking skills and techniques, as well as talking about nutrition education. And we have an accompanying virtual culinary medicine toolkit that lives on our website, which I'm going to talk about more in a second here, but this is the QR code if you'd like to scan it to go to the Nourish website where all of our information is held. So this is just some example of the toolkit that we created to extend the learning beyond just the 5 sessions. So the information included handouts, as well as videos to appeal to different learning preferences. And we provided participants with a printed booklet to make cooking easier. along with the shopping lists for each of the classes. And we did provide incentives, gift cards for each of the classes so that they could actually purchase all of the ingredients and foods necessary to make the recipes. Again, each session was focused on a specific culinary technique and covered diabetes-specific education and nutrition education. And you can see the recipes listed here. Some of them overlap, like garlic and herb buttered broccoli that I mentioned earlier, but in general, rather than being just what we'll call vegetable sides, these included full meals. So again, something that they could eat with their families afterwards. Again, our toolkit is publicly available and you can scan the QR code there. These are just examples of some of the toolkit materials. On the left is a goal setting handout. On the right is the knife skills kind of reminder with links for the participants themselves to be able to link back to the videos that were either shown during the class or that remind them of the technique that they learned during class. So they might learn something during class, but maybe if they've only done it once, they need a refresher. And so this toolkit really allows them to go back and brush up on certain skills that they might have just learned. So the session flow kind of followed this pattern for each of the classes. Diana, again, our wonderful registered dietitian and instructor, is great about promoting an interactive environment in her classes. So she typically starts with a welcome and a check-in of how the previous week has gone, if it's not the first session, obviously. And if anyone wants to share a win or something new they tried in the past week. Typically, participants were eating the meal they cooked with their families from the previous week, so they would share how they and their families liked the food from the week before. We encouraged participants to have ingredients measured out and ready to go at the start of each session, but she would also go over knife skills together, prepping the vegetables together, and she would go on into the cooking process during the class. Then during downtime or when things were simmering or boiling or cooking, she would show our animated videos, which there's a screenshot there. And again, all these are available in the toolkit online. And we had different themes for each class. Some topics included eating with kids or grocery shopping or high and low blood sugar and kind of general nutrition and diabetes education. And that was the typical flow. And then kind of they would end with either signing off for the day or occasionally they would sometimes eat together on screen with the participants, or many would sign off and eat with their families. So this was a study. So we did do some assessments. We had pre and post test surveys where we asked participants to self-report various items, including their perceptions, the perceived barriers, their self-efficacy or their confidence in cooking, along with other variables we'll talk about in a second. We also obtained electronic medical record data. So before the intervention, post, and then 6 months after the end of the intervention. And again, we always conduct in-depth interviews at the end of our studies to kind of see how people like the program and really understand what may have been driving any effects we see in the program. And for analyses, we conducted multi-level mixed effects regression models, and the post-participation interviews used framework analysis. So very briefly, we were able to consent and enroll 104 individuals. However, we did have a lot of people that we lost prior to even receiving a single intervention session. That was because we had a long gap between when we recruited them and when we were actually able to start the program. So that is a lesson learned and something that we're gonna take moving forward into our upcoming program that I'll talk about later. But of those who received the intervention, about 37 completed some classes, 32 completed all 5 classes, and we actually had some people who repeated the program. So it was the same content each time, but they liked it so much that they asked to come back, and we said, okay. And then there was some people that we did lose after the intervention, about 15. So we have 61 people where we have complete data pre and post. So this was our demographic breakdown. It was mostly a female sample, as you might expect, 77%. Over half Hispanic Latino, 28% Black, and then 15% non-Hispanic white. Because we offered the class in Spanish, of course, we have other people. We have people who are bilingual, about half, and some only spoke Spanish. That would be the other language only. It was only Spanish. And then we had varied education. About half had high school education or less, and then some college graduates. So here are our main outcomes. The first column is obviously the psychosocial or the item, then the pretest or the baseline before the intervention, post-test, after the intervention, and then our estimates from our modeling. So all variables kind of did what we expected them to do, which is really great. It rarely ever happens. So we saw statistically significant improvements in servings of fruits and vegetables, frequency of healthy food consumption, a reduction in barriers to healthy eating, which is what we want to see. We want to see less barriers. Again, improvements in shopping, cooking, and eating behaviors, diabetes self-management, and cooking self-efficacy, or confidence, so cooking confidence. We also saw improvements in perceived health, so self-reported perceived health in the past 4 weeks. We saw a large effect size, though that of course has a very wide confidence interval, and improvements in being able to give an accurate estimate of what the My Plate looks like. So we saw improvements, statistically significant improvements in that as well. And clinical outcomes. So we did have reduced numbers for these clinical outcomes because we did pull from the EMR data, and because we didn't explicitly pay for these labs, there was just part of standard of care at these clinics. We did see reduced numbers here. So that affects our ability to detect statistically significant differences when you have small samples. But in any case, everything trended in the right direction. We think that with a larger sample, we would see statistically significant differences, although that's yet to be tested. But we did see statistically significant differences in HbA1c, both immediately after the intervention, but more starkly so even 6 months post intervention. We saw an even greater reduction in HbA1c. Again, all the other variables trended in the right direction, but were not statistically significant, except for that systolic blood pressure that at 6 months post-intervention was also statistically significantly different, very much lowering from baseline for individuals that we have data from. And then again, we did qualitative interviews, and these are just our demographics from the subset of our larger sample who we interviewed. In general, people really liked the program. So why were they motivated to participate? One said, because of my diabetes, I wanted to learn new cooking recipes so I can learn how to eat healthier. Talking about the cooking classes, one said, keep the classes coming. It's something that even if some doctor tells us to eat healthy, we have no idea. If you give us these classes, for us, it is everything. They like the online resources, that toolkit that I have mentioned. So as far as the toolkits, it was wonderful. The videos, all of it was super easy and also accessible. They liked the customizability of the recipes. So one person saying you can mix up which vegetables you're using, so it's really versatile. Another key thing I think here is the sense of community. So one person said, I think it's kind of fun too, because you get to kind of meet other people. We're talking to you about the struggles we've had along the way, and I think that's good. So this is something really important, I think, that I didn't touch on yet. A lot of people learn from each other and learn from hearing questions that other people had that they would ask Diana, learn from each other, just experiences they've had, mistakes maybe they've made in the kitchen. So that I think that's another really important aspect of this program. And then the outcomes, obviously self-reported outcomes. One individual said, my A1C at one time was 11. I believe now I'm down to 8.2. So it's just little changes, checking my levels, not using as much sodium. I never realized like prepackaged good has so much sodium. And then another said, with what I have learned, I pay more attention to the labels. I look at how much sodium, how much sugar it has. Before I didn't pay much attention, and now I do. So of course there were limitations. Excuse me. This study was an uncontrolled pilot study design, so we only had an intervention group, but we're planning to remedy this limitation with another study that I'll talk about that tests the same curriculum, but has a control group. We also had a small sample, which limits our ability to detect statistically significant differences, but that didn't appear to be an issue for us with some of our main questionnaire variables, but it did impact when we had the more limited sample that had EMR data. And lastly, participants in this trial might be motivated to change their behavior. People who choose to enroll in a study like this tend to be more motivated, and so the sample might not be representative of the population we really want to target with these programs. And so just to summarize, this brief culinary medicine intervention was able to significantly improve healthy eating, cooking behaviors, diabetes self-management, cooking self-efficacy or confidence, and perceived health. We saw reduced barriers to eating healthy and to those HbA1c levels, and importantly saw continued improvements in HbA1c levels 6 months post-intervention ending. And we hope that we were able to teach lasting culinary skills to these individuals, and again, send them home with that toolkit, which is available online and is a resource for others to be able to deliver the program should they be interested. So what are our next steps with our culinary medicine programs? We have 2 additional programs that are starting in January, so we're really excited about those. One is more on the diabetes management side, and that's another iteration of nourishing the community through culinary medicine in the Acres Homes community of Houston. And this community is a historically Black neighborhood, but now it's almost half Hispanic as well. And the other program is the Teaching Kitchen Collaborative Trial, or the Teaching Kitchen Research Trial, which falls more into the bucket of prevention of type 2 diabetes and other metabolic related diseases. And so I'm going to talk briefly about each of these. So we have funding for a pilot project through MD Anderson, who in turn, they received their funding from the National Cancer Institute for their Acres Homes Cancer Prevention Collaboration. So the aims of this study are to conduct a pilot study of the curriculum I just talked about in the UT physicians clinics that serve the Acres Homes community to assess feasibility and preliminary efficacy. And so for those of you who are not familiar, again, I'm based in Houston, and the Acres Homes community is there in kind of the northwest portion of Houston. And again, we will explore participant experiences in the pilot study to explain our findings and finalize our protocol for a future large-scale trial. So we'll deliver the program to about 66 patients in 2 clinics that serve the Acres Homes area. You can see them there on the map. They kind of border or are part of the Acres Homes community, and have a control clinic to address that limitation I talked about earlier that sits outside but is demographically similar to the other 2 clinics. And we'll hold these classes on a rolling basis. They're 5 weeks long, so we'll be able to host them back to back. And then we like to have about 11 to 17 participants in each cohort. That kind of just depends, but more than 20 and it's hard to manage in a virtual environment. And less than 10, you tend to have dropouts, and then people aren't learning as much from one another. So we do kind of want to target that range. We're going to collect very similar data to what I just talked about, so I won't belabor this point, but EMR data to capture BMI and HbA1c, those self-administered questionnaires, that baseline and post-intervention that capture some of our proximal or psychosocial variables that we want to see change, that we think then creates the change in diet and then those clinical outcomes. And again, we'll do interviews with participants. And finally, we have our Teaching Kitchen collaborative trial, or our Teaching Kitchen research trial. So this is actually a multi-site trial. It's led by Harvard with funding from the Teaching Kitchen Collaborative, but other sources of funding as well. The sites include UC Irvine, UCLA, and Dartmouth, and then of course our site, which is led by Deanna Holscher and myself. So this class is actually much longer, weekly classes for about 16 weeks, and then monthly for about 8 months, maybe akin to what the DPP is. In this curriculum, there's interactive hands-on cooking instruction, again, nutrition education, along with health coaching that includes a focus on physical activity and mindfulness as well. So kind of getting into some other healthy living behaviors as well. We'll have assessments at baseline, 4 months, 12 months, and 18 months to assess changes over time, and individuals will complete self-administered questionnaires at each of those time points. Again, blood work so that we can track metabolic markers, and anthropometrics so we can track weight and other related anthropometrics. This is our study email and our study phone number. If you are interested in finding out more, I encourage you to email us. I encourage you to probably text us maybe if you want more information, but you can of course give us a call as well. And although I know we have people from many places on this webinar, this one is something that some of you all, at least those of you that are Houston-based, could potentially be eligible to participate in. So we're recruiting from the community at large. Originally, we were recruiting UTHealth Houston staff, and now it's we're recruiting more broadly. So because you're potential participants, or you might know potential participants, I'm including the QR code there that should link you to our page where you can complete a screener and give us consent, or give us your information so that we can give you a call and complete that screener with you. So again, if anyone is Houston-based, if you're a Houston-based organization and you would like to share flyers or learn more, please feel free to reach out to me or the study email that I previously shared with you. And that's it for me today. My email is there in case you have any questions after today, or if you missed any of the links or any of the QR codes I shared today, please just email me and I'll be sure to get them to you.
Thank you so much. That was really fascinating to hear about both of those projects and what you have upcoming. So there are a lot of questions and interest on the recipes for the programs. I know that you shared the QR code for the Nourishing the Community toolkit. Is there, can people access the recipes for the SCAN program?
I believe that the recipes for the SCAN program are actually already listed under recipes on the Nourish website, because they're more standalone kind of single vegetable recipes. I will double check that, and when we send out and share the webinar, I'll make sure that there's a link to those SCAN recipes if for some reason it's not there. But the Nourish website should have most everything.
Great. And can you briefly repeat what SCAN stands for?
Sarah, I don't. Sustainable Culturally Adaptive Nutrition Program.
Oh, wonderful. Well, that actually brings me to another question, as someone was asking if the cooking classes acknowledge ethnic or familiar foods from the participants from other countries.
We do. That is very much a focus, and it's part of the discussion. So for those of you who are not in Houston, Houston is a very racially, ethnically diverse place. So even, let's say, if we have a a Spanish language cohort, you might have individuals from 5, 6 different countries in that cohort, and they eat different foods. And so a lot of the talk when we are talking about the recipes or even making a specific recipes is, what different spices would you use? What different vegetables would you use? And talking through that aspect, because again, we want to make it something that people can continue to use. So in some cases, they're maybe learning about a new, like that day, they're learning about a new vegetable that maybe they haven't used before. And so maybe they'll actually integrate that moving forward because it's something new and they like it. But in some cases, people don't like it. But we talk about what other vegetables that they're more familiar with, that they like, that are healthy, and they can cook, importantly, in a healthy way with the spices that they enjoy. And in some cases, we actually surprise people. So I know in one of the scan sessions, a woman said she didn't like broccoli, but she went ahead and made the recipe anyways that we had, and we surprised her, and she tried the broccoli and she liked it. So it was like the first time she'd ever had broccoli, and the first time she'd ever liked the broccoli that she did.
Right.
So sometimes we surprise people.
Great. Let's see, there was a couple questions about eligibility. Are there requirements to become a part of the DPP classes?
So the DPP classes, so we partnered with Hope Clinic, which is a federally qualified health center here in Houston. So the requirements for that were just whatever requirements Hope Clinic had. So anyone that was enrolling in DPP, typically for that, it's prediabetes. So a certain HbA1c level, having prediabetes to enroll in that. So we didn't have any additional requirements beyond just whatever the clinic was doing for their DPP classes.
Great. And then someone asked if you could review the slide that showed the qualification for the nourishing program, or you might just be able to say those. But also there's another question here. Explain how outreach is conducted to those without computer access or smartphones. As part of the recruitment team for that, I can say that was part of the exclusion criteria. If they didn't have computer access or smartphones, they weren't eligible since these classes were online. So I can answer that one. Do you want to say anything else about well, the slides will be available. So maybe since I have so many other juicy questions here, we'll just say the slides will be emailed out, and so you can review those eligibility requirements again.
Yeah, let me say something about the virtual delivery. So that is so some of these were virtual because you all know what happened, right? So these were starting to be delivered and developed at the time where there were still COVID restrictions. And so it was done for pragmatic reasons, but we found that it does eliminate some other barriers which are related to transportation, maybe childcare. It is hard to cook with a child running around, but it's potentially possible, and it's not possible if you have to go somewhere and bring that child with you. So it did eliminate some barriers. Of course, there are people that don't have a smartphone, but we mainly just required that they have a smartphone. So because they would have internet access through that smartphone. So they didn't have to have a computer or a tablet, though of course those things make it easier to view what's happening and for us to view what's happening so that they can actually show us their meal as well. But it was just limited to that. So most people do have a smartphone, and we did do technical assistance to help people, especially with that first session. So get them familiar with whichever platform we were using, which was different for each one. For one, it was Zoom. For the other one, it was WebEx. So learning how to log on to those and troubleshooting like camera and sound. So there is that aspect of having to build in technical assistance for people at the beginning in order to make it more accessible to more people. But that is always a limitation, but I think can be overcome if you truly put in some work at the beginning to have that technical assistance available.
Right. This other question, I think the next couple are relevant to that point. What would the cost of the program be? Foods, cost of cooking equipment for the participants?
Good question. So we provided, I'm trying to think because I remember we increased it actually. We've increased the amount that we give participants for each of the sessions. Now I'm talking about nourishing the community through culinary medicine, where they're building the larger meal for a family of four. We increased that amount over time because of inflation. So now we're giving them $40 per class. Um, that could, depending on what area of town you're in, what you're buying, what quality of ingredients you're buying, that all varies. But one could estimate that it's about $40 per class over 5 classes, so about $200 to make the recipes. I'm not sure if that answers the question.
I think that's what they were getting at, yeah. Um, and then in your research, how much do the concepts of stress and or busy lifestyle attribute to being a barrier to preparing healthy meals? Is that something that you know the answer to?
I don't, but that is a very good point, and definitely something that, I mean, we know it is a barrier. From the literature, we know it's a barrier, and from qualitative interviews, we know it's a barrier. The answer to how much it's a barrier, I'm not sure. We didn't quantitatively assess that in our study, but I like that idea because it's really important and it could actually drive and affect outcomes, right? So
Mm-hmm.
maybe those with higher levels of stress actually do worse, right? In the
Mm-hmm.
program, for example. So it would be something that we'd want to measure and be able to control and kind of look at the effect that that has, but not something we've investigated specifically in our programs.
And I think from the project management recruitment side of things, we had people who couldn't participate because they were working either multiple jobs or working night jobs. So I think you'd have to really collect a lot of process data on who didn't attend because they either, didn't have time or had
Yeah,
some other barriers going on.
and that's what we saw with SCAN, right? We saw that there were people that were assigned to the intervention that didn't come, and when we were able to at least ask them why not, in many cases it was work barrier, right? Like time, work barriers, and conflicts. So we
Mm.
know that's the reality is that that is a issue of getting people to enroll and participate in our lovely programs that we create. That we want to be able to help them, but time is always an issue.
Yes. Um, I'll answer this one. Are some of the classes or curriculum available online? Definitely yes for well, not the classes, but all the resources from the Nourishing the Community are available on that online toolkit, which includes some of the videos, animated videos, cooking skills videos.
Well,
What about
actually, the
for the
classes
other?
are on there, Sarah.
Oh, that's
So
true.
we do
Yeah.
have, so in the QR code I previously shared on the Nourish website, along with their toolkit, we do have both cook-along classes led by Diana in Spanish and English for each of the 5 sessions.
Yes.
That is an example of what the class could look like. For ethical reasons, we couldn't record the classes with people in them, and so you miss the aspect of what questions they might ask, that tailoring that we talked about earlier related to their preferred cuisines or their preferred vegetables or preferred spices. So you do miss all the aspects of it, and it is thus a shorter video than the 90 minutes. But it is a good example of what things would look like and could be used as a training video. So if
Right.
any organization present here today is interested in implementing the program, you
Mhm.
could, in theory, watch have whoever's going to be instructing your classes watch those videos, and it's a good training of like how the class would flow,
Mhm.
things that you would say, and when you would show the videos and other aspects that are included in the toolkit.
Right. I forgot Diana went back and re-recorded all of those. That was a lot of work. Thank you, Diana.
Yeah, and so
Um,
they're available for everyone.
yeah. So do the cooking recruits participants have to be enrolled in NDPP for the first program you talked about? You mentioned a food RX program. Oh, sorry, that was two questions. So do they have to be already enrolled in DPP?
For the first program, they did. So it was meant to be complement the DPP. So we wanted them to they were just people that were already going to be receiving DPP, and we additionally enrolled them in SCAN if they were interested. So I think that answers the
Right.
question.
I'm realizing that we're at the top of the hour, so there's a couple more really great questions, but we're not going to have time to get to those today. Please tune in for if we have some more webinars coming up this month as well for diabetes awareness. Thank you for attending today's webinar. The recording and slides will be posted on the website, linked in the chat within 2 weeks. We appreciate you being here and see you all next time. Thank you.
Thank you, Sarah. Thanks, everyone.